for this. I'm super excited for this. You're seeing me just make sure my little calculator, which is my phone, is up, so I'm tracking time. I'm excited to be here. Thank you for that introduction. So this is, talking about intersectional health disparities, all sort of around the pandemic. And it's going to be in a series of 3 seminars. So this is seminar number 1, and they all will sort of build on each other. We'll get to that. But, this is sort of navigating, in some ways, starting to create a discourse, not just on some of the health disparities that we know about, right? We know there's racial health disparities. We know there's health disparities for folks with disabilities. We know there's economic health disparities. And there is a lack of intersectional data that is bringing those things together. So as we go along this journey together, we will get there. But first, let me just share a little bit about the overview. So this series overview and where we are today is sort of looking at where we've been. So it's talking a little bit about, based on some of the data that we've had for like 2020, early 2021, like the throes of the pandemic, so to speak, what the impacts have been. And today, the way that I'm going to lay this out is through the social determinants of health, and sort of looking through those 5 categories, some of the data that has arisen. And then, my call to action for y'all today would be to consider, given some of these disparities and the data that is coming, what that means intersectionally, and especially what that means in terms of data that is missing. Seminar 2 is, and like I said, this all sort of continues on with each other, is sort of where we are. So it's taking some of this data, revisiting it, and then also considering what those impacts are as we are reopening or attempting to reopen, what some of that social discourse is around the pandemic, or even perhaps re-emerging pandemics, and how it continues to deepen impacts. In that seminar, we're also going to start to introduce what current calls to action from some of these communities have been or is currently, and how we can start to think about bringing that into our practice and into our work. Seminar 3 is where we're headed. So that's really going to be focusing on bringing in some of the policy proposals, or what some case studies around those calls to action that are going to be discussed in seminar 2, and considering what potential solutions we can use in our work, and moving forward in sort of a cautionary tale of quote unquote returning to normal. Today, the overview of where we're sort of going on this journey is to review some concepts and terms that may be new to you, so that you can understand those as we continue on, not just in this seminar, but in the seminar series. And then looking at those social determinants of health disparities. We'll talk a little bit about what's ahead, and then I want to have time to have some discussion around this, some questions and answers. If there is an answer I don't have, I am one of those folks who I'm more than happy to find some resources and send out after this workshop. And I encourage those questions so that as the seminar continues down the series, that I can have some of that I can incorporate. This is also meant to, as I introduce and I frame this, to be a high level overview. You see here that there's a picture of the stratosphere and the moon that is not necessarily inspired by the space race, but to just show the extent to which I mean that there's a high level overview as high as this picture is. And the reason why is because, as you all know, there is a high, there's so much information, not just that existed before, but also that is emerging, that is really important to consider, that is both historical and continuous. And in these 90-minute sessions, I think it would be a high order to try to to talk about it in depth and detail. It's also important to understand that information is not meant to be seen as homogenous. We might be talking in terms of community, designations, people with disabilities or disabled folks, Black, Brown, Indigenous folks, people of size, but that does not necessarily mean that that can be applied to everyone, obviously. And my hope is that this seminar leaves you purposely with some non-closure and to spark some curiosity around continuing to look in these areas for your practice and for your work. So if after this you would like some additional resources or anything like that, please let me know. And I can share really quick in my introductions and then getting into this material that my background in doing this work is from a lens of social psychology and sociology. Particularly, I have worked in direct social service and social work for about 10 years of my career before I became a social equity consultant. That also includes, as Linda said at the beginning, being someone who is not just a Black and Indigenous, non-binary person, but also I identify as autistic, sick, and mad. So in that sort of, especially chronic illness and autism and things like that, having those lived experiences, it also came out into my social work, which is also something that's reflected in my consulting work, and seeing sort of how these lived experiences and narratives sort of interweave. Or as I like to say, my life's passion is to consider when humans are humaning with other humans, why do certain human things happen? So there's some of this that you might see in that, but also sort of a data nerd. So talking about some statistics. So getting started with just ensuring that we are all speaking the same language, I wanted to talk about some of these concepts that might be important to consider. These are perhaps not your foundational concepts, but some concepts that might be important in considering some of those intersectional aspects and especially nuances of intersectional aspects as we continue along in the series. And part of those questions at the end is if there's additional terms or concepts that you would like to see defined in later seminars. So first, talking about before we can define disability justice, I think it's important to define it in terms of disability rights. So starting there. Disability rights is essentially all sort of pieces of disability inclusion or equity that is centered around the Americans with Disabilities Act, or the ADA, and seeking equal access, opportunity, and protection for all disabled folks. This is something that was pursued particularly in the 70s and wasn't ratified until 1990. The reason why this was important is because when the Civil Rights Act of 1964 was passed, it frankly forgot a lot of people in intersectional communities, and one of those communities were the disabled community. In 1977, I believe, they were able to pass the Section 504 Act, which was more around sort of like vocational access, but not really the spatial access or educational access that was needed to be able to truly live in have equal access to things. So then they continued that advocacy until 1990, when they were able to pass the Americans with Disabilities Act, which was re-ratified, I believe, in 2004 to be expanded. It's not to say that disability rights does not have a place at all. What it is to say is that it's an equality-based model. And equality-based models, especially when we're talking about nuances of intersectionality, does not sometimes get to the root causes of why there are barriers and bottlenecks to access and community integration and participation, but may address more of the surface area or the symptoms of those issues. And especially because it lacks intersectional analysis, it may not really get to the fullness of the issues especially as we start to talk about the pandemic and how those impacts bring in other areas of intersectional disparities, such as race or economics or things like that. It's also a legal or rights-based framework. And what's important about those sort of frameworks is that who has access to policy and legislative action, especially we're talking about 70s, 80s, and early 90s, right? So, and even afterward, to ensure that the ADA works for you, you know, and some of this is sort of in the school to prison pipeline, or to, you know, push out sort of things, you know, you would also have to be able to have access to the resources and the education and the knowledge, say to get your IEP plan together. So if you are, say, a parent of a disabled child who also is Black, Brown, Indigenous, and you're under-resourced and you're on state insurance, and you have to go to a certain specialist to get an IEP plan that is not covered by your state insurance, especially in the early 90s, then you're not going to have access. And so some of those pieces, even if you want to advocate, can also create barriers. So that's where some of those legal and rights-based frameworks can become difficult. In 2005, a group of Black, Brown, Indigenous, queer, trans, and non-binary, and multiply disabled organizers and leaders came together to co-create a dynamic and fluid framework called disability justice. You see here the cover of their primer, the second edition of their primer, called Skin, Tooth, and Bone, the Basis of Movement as Our People. And it's under the organizing home of Sins Invalid. However, it is meant to be open to collective collective input. So in a lot of ways, not only is the primer, but ongoing additions to the canon, if you will, of disability justice is very much based in the essays and narratives and research that are done by disabled folks, especially intersectional disabled folks, and we'll talk about why that is in a second. It is based on a dynamic of centering wisdom versus knowledge. And what I mean by that is knowledge is something that anyone with enough time, energy, and resources can gather. As you see behind me, I love to gather a lot of knowledge. However, wisdom is when you take that knowledge, that information, those data, that statistics, and you're able to also loop in an embodied lived experience that helps you to understand it beyond the theoretical or the intellectual. So for disability justice versus disability rights, disability justice centers those who are the most impacted, being at the forefront of what they need and what needs to happen. Whereas disability rights can still have a bit of a medical model, meaning that those who are clinicians, those who are caregivers, or otherwise may have a sort of hierarchical or credential-based sort of authority, would have more say over how things may go in a disability rights or ADA framework than, say, disability justice, where folks who are the most impacted would be amplified in leadership. And it's based on 10 guiding principles that to date have not yet shifted, although under each of these 10 principles, as you can imagine, with such a large and dynamic framework, there is multitudes of narratives and essays and research that has been done around each of these pieces. But the 10 principles are intersectional, and I'll read them all and I'll go back and explain some of these that may not necessarily be as intuitive. But intersectionality is number one, leadership of those most impacted. So as you heard, that was sort of a theme. Anti-capitalist politic, and I'll come back to that one in a second, because that one's usually the yellow flag one. Commitment to cross-movement organizing, recognizing wholeness, sustainability, commitment to cross-disability solidarity, interdependence, collective access, and collective liberation. So to explain some of the more, difficult to understand ones. Intersectionality, when it's being used, is closer to the original intent of that term and further away to the more contemporary intent of that term. And what I mean is that in our contemporary sense, intersectionality has came to mean two or more lived experiences. And that's pretty much it. Which some would argue is more of a social identity profile than intersectionality. The reason why is because intersectionality traditionally was a coin that was termed by a critical race theorist and legal scholar named Kimberly Crenshaw. And Kimberly Crenshaw coined this term to losing my words, describe the barriers to employment that she found in the 80s and early 90s for Black women, I think in this case, Black cishet women, who were seeking employment at an automobile manufacturing firm. When she went to go see, because these Black women were saying, well, we're not able to get jobs, they are systematically excluding us from work. She went to that automobile manufacturing firm and said, hey, what gives? And they said, we don't know, because we hire Black folks and we hire women, so we don't know. Maybe it's something with their application. Maybe it's something with their qualifications. Well, she found that they were hiring Black folks, but they were primarily hiring Black cis men for back of the house line and assembly work. And they were hiring women, but they were primarily hiring white cis women for front of house administrative client facing work. So in those two situations, Black women were being systematically disqualified from work based on sexism when it came to back of house and anti-Blackness or racism when it came to front of house. So to describe that dynamic, intersectionality was coined. Disability justice is closer to that, where I would say in this case, a good operational definition for intersectionality for disability justice would be two or more historically or systemically marginalized, exploited, or oppressed lived experiences and identities, centering disability plus. So disability plus another experience, and some disability justice practitioners would argue you would have to also be a Black, Brown, Indigenous person in addition to that, since that is one of the highest sort of and most historical entrenched sort of disparities that our country has. The third one is also one that always sort of gets folks' ears perked up, the anti-capitalist politic. And the way to consider this, because I know that the anti-capitalist piece, especially in the last 18 months to 2 years, has become somewhat of a hot button term. Again, remember this was established in 2005. But this you can understand as an intersection of economic and labor justice, and seeing folks not based on their productivity and the extent to which their body minds can produce labor, but to see them, as people who have needs and families and communities. This is particularly true in terms of the sub-minimum wage issues. I know that Washington State finally banned some minimum wage. Seattle, the city of Seattle, I think was first, then King County, and then the state followed suit some 2 years after the county and some 3 or 4 years after the city. Some minimum wage is something that's still entrenched in the Federal Labor and Standards Act that allows organizations to apply for certificates that allow them to pay disabled folks a sub minimum wage. And some of those places that are the most notorious is Goodwill. And I just saw something about Walmart that just came out where I lost a class action lawsuit to a group of disabled folks because of sub minimum wage. Because, there's this belief that disabled folks are either in congregate care or otherwise may not need to, make as much money as others because, whether they have a family or not, or even due to bias because they don't feel that disabled folks' labor and productivity would match what they would consider to be a good cost-benefit analysis for paying higher than the minimum wage. Some minimum wage has persisted, and if not directly, then disparities and bias and the harms in the workplace, which honestly is what most of my clients come to be, is an intersection of this disability and justice around this third piece and the intersection of racial bias in the workplace. So it's pretty common. When you talk about commitment to cross-movement organizing, it's sort of understanding that not only in an intersectional place should we have leadership of those most impacted, but also that disability justice must, by its nature, intersectional nature, also consider economic justice, environmental justice, and in this case, disparities in healthcare, and medical justice. And so if not bringing in those intersectional pieces and having that cross-movement organizing, it doesn't get to really truly bring the equity that it seeks. Some of the rest of this is a sort of more intuitive to understand, but it's something that I would love to send out more resources if you're interested in some of the additional pieces of the 10 principles that come out of disability justice. Unconscious and implicit bias is also one of the terms I wanted to talk about, as you might hear me reference it today. Unconscious and implicit bias and definitions of those are as numerous as your options in the bread aisle. And while that it can be okay, I think for the purposes of this, I think it's important to sort of operationalize unconscious bias as I might be using it. So this is perhaps the Epiphanies of Equity brand of bread when you're going into that aisle. But what's important for unconscious bias to understand, first to define it, it would be the ways in which you understand, navigate, make meaning, and take actions or make decisions based on your lived experience in the world, socialization, historical, and cultural factors. Most importantly, it happens in the automatic part of your brain, which is your midbrain, and it often happens without introspection and meta thinking. That's really the important part I want to operationalize today, is when we talk about unconscious bias, we're talking about unconscious bias. So it's not, so there is conscious bias that is available. And that's sort of when you're, say, waking up in the morning and you're like, I can't stand this person. I don't like them. Forget that person in particular, right? Or you're in a moment and you're like, well, this person must be like this, and you're thinking about it. Unconscious bias is happening like that. Unconscious biases can exist even if you hold conscious beliefs or have conscious awareness of inequity. It is, unconscious bias is the thing that comes out of your body mind. When you are at the 3:45 slump, you're on your 5th Zoom call, you have to pee, the dog is barking, your coffee's wearing off, you haven't eaten for a while, you have a 4:30 deadline, and something comes up. That's unconscious bias. And so it's important to think about that, because those are the pieces that do require us to actively participate in introspection, perhaps at the end of the day or after each client. But it's something that is, it's not saying that you're going into situations and you're like, how can I destroy this person's day? Not saying those people don't exist, totally do exist. That's not unconscious bias. It's also important to consider that bias itself is not a good or a bad thing, it's a human thing. But it is important that we are aware of our conscious biases and we think about our lived experiences and our socialization and our conditioning and our historical and cultural factors, because its impacts and its outcomes, when it's not checked or it's not considered, can be harmful or even worse. So, I have a bias. If I, say I have some clothes in my size, I have a friend who wears my clothing size, I might have a bias to give my friend those clothes. That's just something that we do. It's called affinity bias. We like people who are like us. That may or may not have a negative impact. But if you're an HR manager and you're in a hiring blitz, and you are navigating sort of unconscious biases around, oh, well, this person went to the same alma mater that I did, and they also were in the same honor society, so obviously they would be a good candidate. This person came in with braids in their hair. I don't know, doesn't seem like a very professional hairstyle to me. I think that they should have, straightened their hair for this appointment. That's the those are the times, especially if it's not a conscious thought, when unconscious bias can become quite an issue. One of the last sort of things that I wanted to operationalize today was sort of, what do I mean if I talk about intersectional erasure or racialized ableism? So first, breaking down some of these terms. So ableism, or really anything with an ism, is essentially sort of when you start to create an ideology and a construct around a particular lived experience, meaning that you're also creating bias and assumptions and expectations in ways that you move around those people. Ableism in this case is the bias, oppression, marginalization, etc., regarding the lived or perceived impairment or disability. The reason why I say lived or perceived is because there are some cases where people will assume that you have an impairment or disability when either you don't or you don't identify as having one. Or even if you do identify, it can be even more so. One of the biggest sort of dynamics I see in the workplace around concerns of ableism is seeking accommodations, which would require someone to disclose that they're disabled, which would then open up the opportunity for both conscious and unconscious bias from those folks that they disclose. There's a great article at Limited Send from the Harvard Business Review that talks about some of the reasons why people don't disclose. It could be as much as 40 to 60% of a workforce at any given time, especially with those with invisible disabilities that can mask, is what they would call it, or otherwise perform in such a way, even if it's maladaptive or harmful to them, where they may not show that they have a invisible disability. This could be anything from rationing their insulin so they don't have to go in the bathroom and use it, or ask to use the staff fridge, to not using assistive devices like canes or wheelchairs if they're an ambulatory wheelchair user in the office, and other sort of ways that can sort of mask their disabilities. Racialized ableism is then that compounded harm, violence, and bias at the intersection of racism and ableism. When I say intersection, a good thing to think about is when I talk about intersection, you think about like a pie chart. It's not saying, well, this part, the racial inequity part is blue, and the disability inequity part is red, and the gender disparity part is white. It's saying that the circle is lavender, right? So when we're talking about racialized ableism, in this case, this person would be experiencing racism, and they would share that experience with racism with other folks in their community. They would be experiencing ableism, and they would share that experience of ableism with other disabled folks in their community. And they would have this tertiary additional experience of racialized ableism. So it's important to think about how these impacts compound and also can add to some of the barriers or bottlenecks and distress. So with racialized ableism, with that intersection, it also would include gender, size, color or tone, and class, which can also play a part. When we talk about class, we're talking about economics, and we're also talking about what insurance card they show up to with the hospital, right? How they have access to the transportation to spaces, and the extent to which they might access certain services that are emergency services. I know, as for example, my spouse who has epilepsy very often has yelled at me in cases where I've gotten scared when he hasn't woken up for more than 20 minutes. When he's like, how did I get to the hospital? Did you call AMR? And I would say, yeah. And he's like, why would you do that? We don't have $300 for that. And that sort of response is not uncommon when class in an intersectional sort of way comes in to these situations, and also is something that is very much a dynamic that came out during the pandemic as well. And an intersectional erasure is when there is apathy or a lack of regard for the whole person. So remember in that those 10 principles we had, recognizing wholeness. Well, for the whole person, it might hyper focus on or select identities within an intersection, or it might completely dismiss the possibility for there to be an intersectional piece. So this may be, say, if you're coming in and you're expecting, instead of racialized ableism, you might have someone who hyper focuses on your racial identity and disparities around that, but does not take your disability into account, or might hyper focus, say, on a mental health history, but does not give you the grace of that, of also perhaps having a chronic illness or chronic pain or something like that. So that can be intersectional erasure, and it's often a result of confirmation or anger bias. So example, sort of outside in the criminal legal space, is this person here, who's Matthew Rushin. You might have heard of Matthew Rushin's story last year. Matthew Rushin is a Black and neurodivergent person, but in this case, him being autistic is of the most importance. He was someone who was going to school and working, and working towards that sort of independence and community integration while still relying on some care from his family as caregivers. He was coming home from work and buying some pastries, I think of the Panera bread, and he had some pedal misapplication, which is common, especially for not only younger drivers, folks between like 16 and early 20s, but also those who have diagnoses or neurodivergence that may have poor executive functioning, which is something that those who are neurodivergent, like with intellectual developmental disabilities or ADHD, may have. In the pedal misapplication, he clipped one car in a parking lot, and then he started to go out of that parking lot to turn around, where he had a collision with a second car. In that second collision, there was some injuries, some significant injuries that happened to the other passenger, which caused, of course, a situation where there was a lot of energy, and that led to what someone in the autistic community would say is a meltdown. And especially given that folks were looking at him as, was this intentional? Were you trying to hurt yourself in sort of in your car? And in that sort of meltdown space, Matthew, just wanted to say whatever needed to be said and do whatever needed to be done to alleviate the situation, which then led to to making choices, or being led to make choices that will eventually resulted in a charge and in an imprisonment that would have been several decades. It was during the racial reckoning last year that some advocates, especially at the intersection, disability justice, racialized ableism, started to look into this case and advocate for Matthew Rushin to be released. And he was eventually, due to some pressure that was put, especially on the court, who initially didn't want to reopen the case, but because of the social pressure, did reopen the case. And there was a community leader who said, Matthew made a mistake. Would we criminally penalize a driver who fainted, who had a seizure, but didn't know they had a seizure disorder, who had an allergic reaction? Is it a crime, a moral failing, something worth removing from someone their freedom to make a mistake as a direct result of having a disability? Or is it that being Black and disabled makes a mistake a criminal offense? So in this case, as we transition to the pandemic, it's important to think about how some of these intersectional pieces also come into play, and how there are some of these systemic and institutional sort of impacts that can really bring out some of these disparities, even when it may not feel related to healthcare. These sort of experiences can lead to some of the distrust that was talked about in the pandemic in terms of institutions and anything that you would have to rely on an institution for your safety. And especially as these situations, the last thing I'll say for this is that these situations are not uncommon. There was a Cornell University study where they surveyed nationally 9,000 Americans born between 1980 and 1984 who were disabled and Black, Brown, Indigenous. And they found that Black disabled folks, that more than 55% of Black disabled folks in this particular study had reported being arrested by the time they were age 28. So in this, it helps to show that when we hear these stories and as we go into the social determinants of health data, it's important to consider that these, even if you are hearing it from anecdotal or narrative research, that it is not to be seen as, well, this is just sort of individual people's experiences. But I encourage, not just in this seminar, but in our series, to consider how there is a butterfly effect, so to speak, with some of these narratives and experiences that might be more felt, but similar to disclosing in the workplace, people may not be speaking openly out of fear of retaliation, discrimination, or bias. So let's talk about social determinants of health in the pandemic. So social determinants of health are defined as the conditions and the environment where people are born, live, learn, work, play, worship, and that sort of affect a wide range of health and functioning and quality of life outcomes and risks. There's, depending on where you go, there's, 7, 12, 14 social determinants of health, but really it all comes down to 5 overarching areas. And those 5 overarching areas, as I was trying to create this seminar, I was like, how do I organize all of this? And so I figured that this social determinants of health would be a good way to do that. So the 5 sort of domains are economic stability, educational access and quality, healthcare access and quality, neighborhood and built environment, and social and community contexts. As we go further in the seminar, will be more data and more intersectional data. And the reason why is because as we start into this, the pandemic, as it started, was not capturing data. At first, was not capturing data. At the very, very first, was not capturing data that was looking at disparities. And so I know that in like the first 3 to 6 months of the pandemic, there were some cases where there had to be policy that was passed to require hospitals to disaggregate their data by things like race and class and age. There's some communities where there still is very little disaggregated data, and disability is one of them. And the reason why that's important is because it's a pandemic. it's a pandemic that not only would be disproportionately impacting folks with chronic illnesses, but it would also be leading to additional acquired chronic illnesses and disabilities. And we already know sort of some of how the racial disparities may have played a part. So I shared the disability justice piece because intersectionally, I found this research that as of 2019 shared that 1 in 4 Black adults that they had surveyed had a disability compared to 1 in 5 white folks and 1 in 6 Latina folks, and it was the only intersectional pieces that they had. So, you know, when we're talking about racial disparities, we're also talking about disability disparities, we're also talking about economic disparities, and that's sort of where the messiness of the data that is emerging and that we have so far is sort of falling short in seeing what the true breadth of the disparities are, especially when you start to look at the intersectional data. We know that data analysis and gathering can, especially longitudinally, can take years. So we might be waiting a decade or so, right? Starting with economic stability, some of these pieces, you know, are just sort of sharing the data. And again, like I said in the beginning, I encourage as we go through this to consider if this is true for this, and this is based on what I could find so far that isn't sort of the data for now, because I'll be the second seminar. How does these sort of intersectional pieces, are the leadership of those most impacted? Is it, you know, is it considering sort of the wholeness of people that could be coming out? So while I couldn't find, you know, I think that there's some emerging data that's coming out now around economic instability that's happened. There certainly has been a what I think Biden started to say, a K-shaped recovery. And we're still sort of looking at the extent to which a K-shaped recovery is impacting. But as of 2019, 1 in 10 people in the United States live in poverty. And according to, I think it was the World Health Organization in the United States, that it's about it's almost 10% of the country is living in food scarcity. And that, of course, goes higher as you leave wealthy countries like ours. There's also in the economic pieces, it was really difficult. You know, social distancing was a privilege that we didn't really talk about. There's a high likelihood of disabled folks, younger folks, under-resourced folks, and Black, Brown, Indigenous communities to live in multi-family, multi-generational households, sometimes with elders, other high-risk populations, such as disabled folks or young children, and an inability to social distance, especially if they were living, say, in apartment-style living, where they don't have very much square footage to have those 6 feet. There's also a huge disparity came out in terms of essential workers who did not have social distancing options. This was particularly interesting, especially in some organizations where I was a consultant during the pandemic. There was definitely a tale of 2 worlds in that there were some folks like myself who, you know, just took their den and turned it into an office, and then we just sort of played Brady Bunch squares for the last 18 months. And there was other folks who it was almost as if that sort of area of the pandemic didn't occur for them at all. In fact, my spouse is someone who works at a residential facility for disabled folks, and talked and shared with me the other day that he still doesn't know how to use Zoom because that wasn't something that he had the privilege of using. In particular, these essential workers not only couldn't work from home, but they also likely couldn't afford to reduce their hours and had other barriers to employment where this was possible. They were also likely underinsured, especially if they were gig workers like Uber drivers or Lyft or DoorDash or Instacart or some of those other sort of spaces. You know, we've been thinking about sort of through the pandemic, how that has led to increased disparities of who contracted COVID-19, how long they waited to get tested, if they had access to testing, how long it took for them to even seek out health care if they were sick, and the extent to which they felt that that was an option for them, especially if they were the person who was bringing in the majority of the funds for the household. At the beginning of 2020, late 2019, some data I found was that folks who identify as women, unfortunately, this again, I think is for cis women, they didn't have LGBTQIA plus based data in this particular survey. But women make up the majority of essential workers in healthcare by 76%, and government and community-based services by 73%. And by government and community-based services, meaning those services that still required community-facing work. Primarily, I think in Seattle, King County, they talked about outreach and supportive housing, shelter care, things like that, where people really needed to have access to folks. Black, Brown, Indigenous folks make up the majority of essential workers in food and agriculture by about 50%, and 53% of industrial, commercial, and residential facilities and services across the country. And nearly 70% of essential workers don't have a college degree. Around 3 in 10 essential workers had some college or high school diploma, which I was about 29%, and 1 in 10 have less than a high school diploma. So when you think about this, especially in terms of a city like Seattle, which is very degreed, very educated, and also have a lot of barriers to advancement or to jobs that would allow for social distancing based on the sort of privilege, the class privilege you would have for a degree. This could also lead to why there was such a disparity, perhaps, especially along the lines of class, and then also those intersectional lines. Not to mention, especially as we'll dig into more in the second seminar when we talk about where we are currently now, the housing and rent crisis definitely became a burden. The housing crisis in particular, because while the rent was frozen, most places had a rent moratorium, there were increased reports of unsanitary and unsafe living conditions based on the lack of response by property managers and landlords to make necessary repairs. As a result, there had been some folks who became sick with other sort of illnesses that were not COVID-19 related, or such as pneumonia, or if there was mold spores that could have caused exacerbations in asthma, things like that. But that also would then lead to an increased not exposure, but again, losing my words. People will be more likely to be impacted by COVID if they were exposed to it, if they were also to have these issues as well. Education, access, and quality. There is very, very little intersectional data reporting. It seems to be that of the dearth of research that there is either focus on class, economics, race, disability, or perhaps parents and caregivers, especially those of marginalized genders who have traditionally been sort of pushed into caregiver roles, and the impact that has had on careers and people's ability to work, especially whether they're in dual parent households or not, but especially those who are single income earners who are also required to be caregivers. The K through 12 educational impact was something that we sort of saw come through pretty substantially. I think especially in terms of the ways in which the virtual classroom environment was able to accommodate not just those who had children with disabilities, especially those with intellectual and developmental disabilities or other forms of neurodivergence, and the sort of equality-based, so coming back to that sort of issue, the equality-based sort of approaches that, especially in the beginning of the pandemic, that some K through 12 educators took. And I should have wrote down the child's name, but there was a child who was Black, who also was neurodivergent, who was suspended because they were not completing their work, but they were not completing their work because it was difficult for them to access their classroom, to have a quiet place to think and to learn, because they were in one of those multi-family, multi-generational household situations. And so instead of approaching it sort of with perhaps an IEP plan or something like that, the child was given a punitive sort of approach, which also kind of came out into the news later. But we also saw how access to internet and sources of information about the pandemic or vaccines were an issue. There was quite a number of information that to get clear sort of direct information required an internet, either on your phone or a computer. Seeking vaccines was also something, as that came around, that required navigating the internet or somehow having access to information that would require folks to be in very strategic spaces. So not only was the access to internet a disparity that folks didn't really think about in terms of access to education for K through 12, it was also something that was not considered in terms of access to information for the pandemic itself. Not to mention that even if you had internet, depending on your other factors, you may not be able to access certain information, especially as more and more news sources put information behind paywalls, which some news sources decided to drop and others did not. So, at the base of it, having information, and we'll talk a little bit about this in another space, but I think it's also important here to mention having access to information that people were able to educate themselves based on their level of understanding. That was plain language, that was ASL. There's a lot of conversations about ASL interpreters during pandemic speeches and updates, having things in Braille, there's things like that that make sense. There was also important to consider, especially when we talk about plain language, of the dearth of research that we have that's intersectional or about sort of the impacts of this. One of them, and sort of going into the healthcare disparities, was from a New York Times article. They quoted and collaborated on a study from 2020. As of April 6, 2020, in New York, the COVID-19 death rate among adults with intellectual and developmental disabilities receiving services in the state was 9.5%, compared to the death rate at that time in New York of 4%. And some folks argued that that was because there wasn't really access to information in plain language that would allow, especially folks with intellectual and developmental disabilities, to truly understand, perceive, and be aware of not only what they needed to do to stay safe, but also what they needed to do to find help. It also, the implicit and unconscious bias within not just our healthcare system, but also our demographers, our statisticians, our journalists, and all of those intersecting institutions can impact the educational access and quality for us. In a research study that I found from some disability studies scholars, they argued that in prior years to the pandemic, nearly half of death certificates for adults with intellectual and developmental disabilities, some 48.5%, inaccurately reported their disability as their cause of death. So since yeah, so since the inaccurate coding of IDD on death certificates was so prominent in prior years for individuals who died from, respiratory disease in particular, which is what we're talking about, they argued how important it is during the pandemic to ensure that those who are completing the death certificates were folks with IDD who died from COVID-19 report COVID-19 as the cause of death, at least in the part 1 of the certificate, and then, if necessary, add the disability in part 2 of the certificate. Because if we continue to fail to accurately record cause of death, we will never truly fully understand on the full effect of the pandemic. So going to the healthcare access, now speed up just a little bit, but we're mostly done, just so we have some time for questions. But with healthcare access and quality, the first piece is healthcare costs and rationing care. So this is, going back to that ambulance issue. One statistic I found is adults with disabilities are 2.5 times more likely to report skipping or delaying healthcare because of costs, and that includes rationing medicine. And sometimes that can mean rationing medicine that can lead to exacerbation of pre-existing conditions that are comorbid with the COVID-19 and the death rate, primarily diabetes and rationing insulin, or even asthma and rationing inhalers. And I will share as a self-disclosure, in the beginning of the pandemic, I used 3 inhalers, and one of my inhalers was not covered for a period of time until I advocated. It was $400 for my steroidal inhaler. I had to save up, even as someone who I would assume is starting to be solidly middle class, and I had to ration my steroidal inhalers in the middle of the pandemic. So I know that if I, in my station, had to do that, thinking about how many other folks have had to do that as well. And that was with, as I said, a partner who was coming in and out of working in a long-term residence where the COVID-19 pandemic, luckily there wasn't an outbreak, but there was almost one. That was so scary. There's also, so there's those pieces of what that looks like. Also, fatphobia and assumption of bias in fatphobia. This is something that is really not talked about and is very intersectional for both disabled folks and class, economic inequality, and racial disparities. A lot of times is going together in that whole mix. Fatphobia is essentially, and some folks say not to use phobia because it isn't a fear of folks of size, but more of a bias or hatred towards folks of size. And some of the surveys I found, as much as 50% or more of primary care doctors who were surveyed viewed patients with obesity, and I'm quoting, as awkward, unattractive, ugly, have less respect for patients with obesity, also believe that heavier patients are less likely to follow medical advice, benefit from counseling, adhere to medications, or also may see them as slovenly or intentionally unhygienic. So all of these things, right, that you need, folks. There's also another study that I found that physicians tend to engage in significantly less rapport building, especially even emotional nature, such as empathy or concern or self-disclosure. And that a recent study of a large cohort of medical students at Cornell found that 74% exhibited implicit weight bias and 67% endorse explicit weight bias. So, on top of that, they found that another study I found that 55% of some people of size that they had surveyed said that they have explicitly canceled a doctor's appointment because of their fear of being weighed, and that weight at the beginning of the appointment impacting their quality of care. So especially when you bring in some of these intersectional pieces, and I think even especially with folks with disabilities who are taking medication that leads to weight gain or, lack of access to nutritional food, that would also lead folks to not trust and or access service, as well as, even if they did, receiving less than stellar quality of care. Coming back to the inaccessible health information, if you can't really, if you don't really know where to go or what's going on or what signs or symptoms to look for because you don't have access to that information, it's going to significantly delay not only seeking care, but also increase those disparities for obvious reasons. Lack of access to primary care doctors and medical centers within neighborhoods is an especially large disparity that came out of this, particularly because, communities with majority Black and Latinx populations are more likely to have limited access to primary care physicians and medical facilities, because private medical providers in particular tend to steer away from neighborhoods that are less likely to own insurance and have less financial resources. And then there's also the bias of what happens when you come in with your Apple Health, or you come in with your Medicare, or you come in with your Medicaid card, and how that has led to disparities even before the pandemic, but has in some cases there's studies being done now to see if it has also led to deprioritization of care based on sort of what treatments would be covered by insurance, for example, as opposed to if they were to have private insurance. A similar problem came to be when it came to COVID-19 testing. So they found that testing sites in one study I found, testing sites in Black, Brown, Indigenous communities were more scarce and understaffed. And again, because private medical providers were less willing to set up those testing sites in those communities, or felt that they perhaps may have less engagement, so wanted to prioritize the vaccines and the testing in spaces where they thought people would be more likely to use it. And then that would require those folks to travel to those neighborhoods, would either require them to get on public transportation or otherwise find ways to take the test or to get a vaccine. And I know that particularly in a class issue, if you don't have a car, you couldn't do the drive up, right? And then you usually could, if you couldn't stand, you couldn't do the walk up. So how are you supposed to get the vaccine or get the testing without a car? So the car in particular became a symbol of inequity and disparities during this period, as more and more folks who didn't have that were sort of left to navigate other resources that didn't really exist. And then, of course, racial bias in healthcare, not just towards Black, Brown, Indigenous folks, but also Black, Brown, Indigenous folks, in a lot of cases, not having a lot of reason to trust these medical care. We kind of go all the way back to the Tuskegee experiment, but we don't have to go back that far. We just have to go to now. Look at some of the data and statistics of racial disparities and bias. The mortality rate of birthing folks, the Black, Brown, Indigenous birthing folks, the disparities of who's more likely to die of a heart attack in the ER than other folks, things like that. So, so even back in this, there's something I found that in April 2020, in April 2021, when testing was less readily available, that Black Americans with COVID-19 symptoms were less likely to be given a COVID-19 test. So there became sort of this ripple effect of what's the point if they're just not going to give me the test or not going to care, just going to send me back and say it's in my head. In terms of the neighborhood and built environment, again, transportation access and use. Going on the bus during the pandemic was a scary thing for some folks, and especially because paper masks or even cloth masks cost money. So there were folks who were using less than stellar protective equipment. I heard everything from using bandanas that they didn't really have the opportunity to wash them regularly, to not being able to find and or afford hand sanitizer. So they would just buy rubbing alcohol and pour it on their hands and hope for the best. And some folks said it made them feel like, what was the point? It wasn't really going to help. Food insecurity was also a thing. There was a lot of food hoarding that was happening, which means less access to food, and also having to go into grocery stores more often. So there wasn't really an ability to find food if you weren't in a food desert or, dependent on certain food. And on top of that, the cost. We all know that the cost is rising and has risen, and the limitations around being able to access food. So if you're on, SNAP benefits or food, what they call food stamps, you only have so much food that you have to be able to use, and there's only such certain food that you can get. So whereas there might have been community centers, especially for folks experiencing houselessness, to buy raw ingredients and cook them somewhere in a community kitchen, because you can't buy hot prepared food, they would then have to be relegated to either eating food that they could cook, sort of camp style, or cold prepared food, or otherwise food that wasn't very nutritious and could lead to worsening health that would make them more susceptible to COVID-19. This also showed that congregate care reform was needed, and emerging reports indicated that residents in institutions and group homes and nursing and other large long-term residential care facilities are at far higher risk for infection and death. And it was also emerging that guidelines about the visitations and infection control procedures, which are the key dimensions of the disease control and access to support, were not only limited, but also inconsistent across states, and primarily based on political lines. There was also some aspects where there is a lack of access to clean water, in particular the Navajo Nation and places like the various sort of pipeline fights. I think Flint, Michigan still doesn't have water unless Will Smith's son brings it around. Doesn't have clean access to water, so it would be hard to practice the sort of hygiene and environment and spatial cleanliness that was required to really maximize the pandemic or exposure to the pandemic. And then finally, environmental racism and impact. One of the number one determinants of whether you're going to live next to toxic air, soil, or water is race. And Black, Brown, Indigenous neighborhoods in the US are shown to be more exposed to air pollution, which again is another risk factor for the development of severe cases in COVID-19. There is an area in New York City called Asthma Alley. I think it's in the Brooklyn area. And they, before the pandemic, had 21 times the other boroughs of hospitalization of around asthma. So they also had an increased COVID-19 death rate and contraction rate. And it's because of not only having asthma and respiratory issues based on the high amount of air pollution, but also that air pollution being a carrier for the COVID-19 virus. And then finally, in the community and social and community contexts, social capital was definitely a big piece of this. Social capital essentially means shared group resources, impact, and access to information. One of the big pieces under social capital is what they call network impoverishment. Network impoverishment means that if you are hurting for $100 to make sure you pay your rent or your mortgage, or you need $50 to be able to buy formula for your baby, that you would be able to go to someone in your family or in your network and be able to either crowdsource that or get a loan, or someone can float you that money. Network impoverishment means that you can't do that. And especially even here in King County, they have found that some folks have been evicted for as little as $11 because they cannot gather that much money in their network. So people may not necessarily have that access. It's also why you saw sort of a huge surge in community mutual aid efforts, so that folks could increase the social capital, and as well as provide information, in a way, in advocacy in the healthcare, in a way that could help to create those disparities. And of course, racial disparities abound. As of March 2nd, 2021, I found some mortality rates of COVID-19 that just shows the impact. 1 in 390 or 256 deaths per 100,000 Indigenous Americans died. 1 in 555 Black Americans, or around 180 out of 100,000, died. 1 in 565 Pacific Islander Americans, or about 177 deaths per 100,000 died. 1 in 665 white Americans, or about 150 deaths per 100,000 died. 1 in 680 Latin Americans, or about 147 out of 100,000 died. And about 1 in 140 Asian Americans, or about 96 deaths out of 100,000 died. And there are some statistics, I did not capture it here, that are starting to navigate the extent to which some of those deaths were preventable, and to what extent they were preventable based on the racial disparities in some of these social determinants of health that the pandemic has impacted. And it's also impacted drop in life expectancy. They have not, of course, had this for 2020 to 2021 yet, but this is, as you can see from PBS, the source is the National Center for Health Statistics. And it showed that in 2020, we lost time. The life expectancy for the average American dropped. It was less so for non-Latina white females they have here, where we lost about 6-7 months, and it was most impactful for non-Latina Black males, where they lost about 3 years in the life expectancy. And as you can see, it has non-Hispanic Black males, Hispanic males, non-Hispanic Black females, Hispanic females, non-Hispanic white males, non-Hispanic white females. They did not have intersectional data here in terms of non-binary gender diversity, which I hope that they could have that intersectional data. But it shows how the health disparities have also impacted our life expectancy, and that's as of 2020. So we will see, hopefully they continue this study longitudinally to see if this will increase. On that note, a look ahead to next seminar will be a continuation of this conversation, but like I said, coming from where we've been to where we are, and starting to see how these disparities continue to worsen, and to what degree intersectionally as the data emerges now, and especially the data that is being used as we focus our, as I said, attempted re-emergence from quarantine, and some of the reasoning and the discourse around that reopening. And also what some calls to action or advocacy has been from intersectional communities and communities around some of those areas we discussed today, especially in terms of policy and what folks are looking for from employers, educators, landlords, everyone sort of in this intersectional society and soup, where these disparities are not just happening based on their health, but also happening based on how they're able to continue to navigate and survive in the world. And I think also starting to have some conversations and leading into seminar 3, we'll talk about what are some ways that we can incorporate this data and some of these calls to action to our work so that we can move forward in equity without trying to, quote, return to normal. So with that, we still have 8 minutes left for questions, things like that. But if you have any additional questions for me in between this and the next seminar, you can find me at the spaces, email, or in my website or anything like that. And yeah, I'm just looking forward to any feedback you also would have to continue to ensure that this seminar series is as informative as possible. So.
Yes, please use this space as we're ending early to ask any questions of ChrisTiana, if you have any, and you could put them in the chat box, or you could just unmute and you can ask them. We got a comment and it says, "This has been really great. Thank you, Eris."
Thanks so much. And just really quick, I thought this is really great, ChrisTiana. Thank you so much for the lessons and all the resources. It's a lot to take in and think about, and I really appreciate it. Would you, I know you had a ton of resources you mentioned, but could you send a couple, like a few of the kind of the most important ones out? Would you be willing to do that? And I think for me, some of that grounding literature kind of on those frameworks would be really valuable.
Yeah, definitely. I have just because it's just the work that I do, especially I love these sort of opportunities because I can increase my nerdiness. As you see, I love to read and learn. So I can definitely make that resource list. I have a whole bookmark tab of all the resources I use for this and for the rest of this seminar series as I keep going. So I can definitely send that your way.
That'd be perfect. Thanks so much. Learned a ton.
Yeah, oh, Jill, did you come off of mute? Would you like to ask a question?
I did, and I do have a question. First, thank you so much. I found this really informative, and I hope to take this information back to our staff. As a question, do you anticipate seeing more intersectionality in terms of research and data moving forward? You mentioned, not having any to present and that none or very little has been done at this point. Do you anticipate a change in that?
It's difficult to predict. And the reason why is because intersectional data, whether qualitative, quantitative, is something that doesn't really exist very much currently in academia, in demographer reports, in any of, in research. I think it's something that, because of the pandemic and because of the complicated, nuanced nature of the disparities that came out, I think that if this is a time, if any, to really consider what does it look like to have intersectional data? What does it look like to start to expect cross tabulations based on identities and intersectional identities in our review, especially of anything that's sociological, political, cultural, that has to do with humans, because we are all prisms of experiences and identities and backgrounds that really does need to have that data. Linda has been working with me in various capacities in the last, I feel like, 5 or so years, and can tell you that I have essentially decided to fight to the death on the hill of the need for intersectionality, increased intersectionality in academia, and especially in research. And in that, also incorporating narrative and qualitative data in our research, and being in not relying so much on quantifying sociocultural and sociopolitical experiences. My hope is that, given what we've seen, and I, I'm calling this time the masterclass of inequity. There is so much of these disparities that I think, especially as a consultant, as an organizer, I've seriously, for a lack of being flippant, taken a sort of attitude like, it's been really, I think frustrating, given sort of, some of the discourse ahead of the pandemic, that we still don't have intersectional data, and intersectional frameworks for research is still seen as perhaps not taboo, but definitely seen as something with a lot of barriers that folks are like, well, we just maybe down the road. And I think down the road is now. So I'm hoping. But I do think that it's going to be us advocating in our spaces. If we have decision or resource holding power around grant requirements for research, we are in research teams. We're able to talk about our methodologies. I think that it's going to continue to have to be a conversation, and really, really, especially within academia and research, to move that needle forward.
Thank you for that. And it's both sobering and refreshing to hear you speak from that perspective. So thank you.
Yeah. Awesome. So just a couple announcements before you all leave. One, we will send you some resources. So I'll work with ChrisTiana to get that some compiled for you. We recorded this video, but it won't be available for another few weeks. But you will also get this video. And sometime this week, you will also get an email regarding a post survey. And it'll only have 2 to 3 questions on it. So you can always just answer it in the email form, but it is really helpful for us to be able to service our grantors and continue this work and to offer this information to the community for free. And I will send you updates in terms of the next seminar and hope that you're able to attend. And that's all. So thank you for attending. Thank you all for taking time out. I know it's the end of the day. And have a great rest of your evening.
Thank you.
Bye.